بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the second part of the lecture dealing with peritoneum and mesenteric imaging, and I have explained in the first part of this talk most of the peritoneal pathology, and in this part I will discuss some of the mesenteric abnormalities, and I remind you that the folds of the peritoneum that are attached to the stomach are known as the omentum, and we have the lesser omentum attached to the lesser curve of the stomach, and the greater omentum which is attached to the greater curve of the stomach. And the greater omentum is 4 layers, and you can see this is the stomach and this is the lesser omentum, and this is the greater omentum, which is 2 folds of the peritoneum. Then they are reflected back, reaching the transverse colon to form the mesocolon later on, which is connecting the transverse colon to the posterior abdominal wall. Then you remember that one of the tools for evaluation of the mesentery and the peritoneum is the CT scan, especially if it is performed after intravenous contrast injection. And one of the essentials in this scan is to obtain the coronal reformatted images of the abdomen, looking for the mesenteric root identified by the superior mesenteric artery and vein. And in this image you can clearly see the root of the mesentery and the 2 vessels, as well as the the branches in the mesentery, and you can see also the mesenteric fat planes. Then as you know that the greater omentum and the lesser omentum cannot be usually seen on CT scans unless they are abnormal, but the normal greater and lesser omentum are not usually visualized. But in the abdominal scans you can say that this is the site of the greater omentum, which is immediately posterior to the anterior abdominal wall, and this is the fat most likely present in the greater omentum. Then these are the abnormalities we would like to expose. Number 1, the rotational anomalies, vascular lesions, mesenteric panniculitis, foreign bodies, mesenteric cysts and malignant tumors, and metastatic disease, and finally the pseudomyxoma peritonei. And malignant tumors include a large group of tumors affecting the peritoneum and mesentery, especially the mesothelioma, liposarcoma, lymphoma, leukemia, and the aggressive fibromatosis. Then you remember from the anatomy that this is the region of the pancreatic head identified by the superior mesenteric artery and vein. And this is the normal relation between the superior mesenteric artery and the vein. The artery is near to the midline, smaller in caliber than the vein itself. Then sometimes in cases of mid-gut rotation or abnormal rotations, you got abnormal relationship of the superior mesenteric artery and the vein. And in cases of volvulus of the mid-gut, you will see the region of the superior mesenteric artery and vein with multiple whorl-like shadows, almost similar to this what we call the whirlpool sign. And of course, because of this volvulus, you will get some obstruction in the intestine, and this is reflected by dilated bowel loops with multiple air fluid levels inside the loops. Then this is one of the uh, previous techniques for evaluation or the demonstration of the abnormal rotations in the gut, and this is a simple non-rotation of the gut. You see the colon is to the left side of the patient and the small bowel are to the right side, and this is almost asymptomatic. But whenever there is a volvulus and you got abnormal relation between the superior mesenteric artery and the vein together with the whirlpool sign, you will expect some form of intestinal obstructive changes. And this is also a good example of mid-gut volvulus. This is the region of the superior mesenteric artery and the vein, and this is the root of the mesentery. Then you got the classic whirlpool sign, and you see the intestine is filled with fluid, and you can also appreciate multiple air fluid levels denoting intestinal obstruction. And this is also a good example for mid-gut volvulus, and you see the classic whirlpool sign at the root of the mesentery. Then partial rotation means that some of the organs are not normally seen at their anatomic sites, and this is an example of a partial rotation of the cecum. The cecum is normally present in the right ileum fossa, but here you can see that the cecum and the ascending colon are to the left of the spine, being in the left lumbar region. Then one of the lesions that may affect the mesentery is thrombosis of either the artery or the vein. And this pathology can be easily diagnosed using the usual multi-detector CT or even the CT angiography of the mesenteric vessels. And in this case, you see this is the aorta, and the vessel coming from the anterior aspect of the aorta is the superior mesenteric artery, and you can appreciate the presence of a thrombus inside the artery. There are many causes for thrombosis of the artery and the vein, including the blood dyscrasia, the trauma, portal hypertension, infection, and malignancies, and sometimes the oral contraceptive pills. In this case, in the same case as of the previous image, and you see the superior mesenteric artery is partially occluded by a thrombus, and looking for the intestine, you see the intestine is dilated, and there are fluid levels denoting some obstructive changes. Then the diagnosis of mesenteric vein thrombosis is easy also during the usual contrast enhanced CT scan of the abdomen. Here you can see the superior mesenteric artery, and this is the vein, and the vein is partially opacified, denoting the presence of a thrombus inside the vein itself. And the patient had also some ascites, as you can see. Then one of the lesions affecting the mesentery is known as mesenteric panniculitis, and this is an inflammatory condition of unknown etiology, and it involves commonly the jejunal mesentery, and the presentation is by abdominal pain, diarrhea, sometimes intestinal obstruction, or the appearance of a mass. However, some of these lesions may be absolutely asymptomatic. If you look carefully for this CT scan of the abdomen, then you see an area of abnormal density of the mesenteric fat. And this area, inside the area, you can see some of the mesenteric vessels going inside the lesion. And what is very important for the diagnosis is that the fat around the vessel is more or less preserved. and this is what we call the fat ring sign. You got an abnormal density of the mesenteric fat localized at any site, usually in the upper abdomen, and you can see the mesenteric vessels going through this abnormality. And if you look carefully, you may see that the fat surrounding the vessels is more or less preserved, and this is what we call the fat ring sign. And after healing, calcium may be deposited in this lesion. And once more, this is a case of mesenteric panniculitis, and you see abnormal density simulating a mass in the upper abdomen, and through this mass you got the vessels, and the vessels are coursing through the abnormality itself, and you can appreciate the preservation of the perivascular fat. Another example of mesenteric panniculitis, and you see the abnormality, and you see the vessels are coursing through this abnormality. Then we came to the peritoneal and mesenteric cysts, and you know that there are a lot of cysts that can occur in the peritoneum or the mesentery. Some of the cysts are unilocular, and others may be multilocular with internal septations, particularly the cysts related to the lymphangioma. And sometimes you got cystic mesothelioma or non-pancreatic pseudocysts within the mesentery. Also, the presence of a thick enhancing wall is suggestive of an enteric duplication cyst. Then if you see a cystic lesion in the peritoneum or in the mesentery, then the cyst is containing fluid, and the wall is thin with no internal septations, and there is no enhancement and no mural nodules. Then you are not able to predict the nature of this cyst, and the diagnosis is usually in most of the cases as a mesenteric cyst, and sometimes this cyst may be aspirated percutaneous or may be surgically removed. And look at this example of a cystic lesion in the pelvic abdominal area of a female patient who had a positive history of trauma followed by abdominal pain, and a cystic mass is suspected to represent a pseudocyst secondary to the traumatic insult. And because of the thickness of the wall, an abscess was also suspected, or an infected mesenteric cyst. At surgery, this was found to be a mucinous cystadenoma of an ectopic ovarian tissue. Then what I want to say that whenever you see a cystic lesion in the abdomen, there are some criteria to predict one of the lesions, but in many times you cannot predict, and you say only this is a mesenteric cyst for further evaluation. One of the criteria to predict the nature of the lesion is the presence of internal septation, and the cyst is creeping in between the abdominal organs, and in such case you can predict the nature of the lesion as a lymphangioma. Lymphangioma is a large lesion, and it's multilocular with internal septations and clear water contents. And this is an example of a lymphangioma in the abdomen. You see a huge cyst with internal septations and clear fluid density. And this is also a lymphangioma in a female child. You see the huge distension of the abdomen by this very big cystic lesion with internal septations displacing and compressing the bowel loops. Also, one of the criteria to predict the nature of the cyst is the presence of fat and calcium. and inside the cyst, and in such cases it is an easy diagnosis, and the cyst usually presents the cystic teratoma. And here an example of a big lesion containing fluid, containing fat and calcium as well. Then the presence of fat and calcium in a cystic lesion in the peritoneum is suggestive of teratoma. And you know that these two major criteria, calcium and fat, can help in the to predict the nature of teratoma anywhere in the body. You remember in the mediastinum, and also in the ovary, when we will discuss the imaging of the female pelvis. One of the two criteria are helpful to diagnose ovarian dermoid cysts. And this is an example of a cystic lesion in the peritoneum or in the mesentery, fluid filled with no internal septation. Then the diagnosis is a mesenteric cyst. And you should know the differential diagnosis as I have mentioned. Then peritoneal mesothelioma is a rare tumor of the peritoneum compared to that of the pleura, and most of the peritoneal mesotheliomas are also associated with asbestos exposure, and about 35% of mesotheliomas can arise solely in the peritoneum. But in some cases, you can see mesothelioma in the pleura extending through the pleuroperitoneal recess into the abdomen, or there is an associated location of the tumor in both the chest and the abdomen. And you remember that this is the site of the greater omentum, and you see a big mass which is infiltrating the greater omentum, which is posterior, just posterior to the anterior abdominal wall. The best diagnosis for this appearance is the peritoneal implants, or what's known as omental cake, especially if you know that the patient had a primary malignancy that can metastasize through the peritoneum. But in many cases, there is no known primary, and you have to biopsy these masses in order to know the exact nature. And mesothelioma may appear as I have shown in this case, and may also be in the diffuse, or what's known as the desmoplastic type. And this diffuse type is an infiltrative lesion involving the peritoneum and encasing the intestinal lobes. Actually, as I have mentioned, you cannot predict that this is a mesothelioma from imaging, and you should have the histopathologic confirmation by either by surgical biopsy or by CT guided needle biopsy or ultrasound, of course. Then liposarcoma is of the peritoneum is very rare, and you know that the most two common sites for liposarcoma are the lower limbs and the retroperitoneal area. But intraperitoneal liposarcoma is very rare, and it has a poor prognosis. The diagnosis of liposarcoma depends on the detection of a mass in the peritoneum which is containing fat and other tissues, soft tissues other than fat. Then if this mass is formed only of fat, you may suspect a peritoneal lipoma, but you look for this example, a big fat containing mass in the right side of the abdomen and pelvis with fine internal septation displacing this bowel to the left side, and this was suspected to represent just a peritoneal lipoma, but it was confirmed to be a liposarcoma. Then lymphoma, one of the lesions that affected the retroperitoneal as well as the mesenteric lymph nodes. And you remember that the nodes of lymphoma are bulky and amalgamated and homogeneous with, in most of the cases, no internal areas of breakdown. And you see bulky lymph nodes encasing the aorta and bulky lymph nodes in the mesentery as well as in the iliac regions as well. The sandwich sign refers to the enlargement of the mesenteric lymph nodes surrounding the root of the mesentery, and here you can see that the two layers of bulky amalgamated lymph nodes encasing the mesenteric vessels, forming what's known as the sandwich sign. Then diffuse type of peritoneal lymphoma may appear like this, and you got bulky amalgamated soft tissue masses infiltrating the peritoneal reflections as well as the mesenteric fat encasing the intestinal vessels. And this appearance is suggestive of lymphoma or any other diffuse malignancy that can affect the peritoneum. And this is a pathologically proved case of non-Hodgkin lymphoma of the peritoneum. You see the huge masses infiltrating the peritoneum and encasing the bowel loops with multiple encysted fluid collections in between. Then peritoneal metastases are the most common neoplastic peritoneal lesions compared to the primary pathology, and the metastases are usually affects the peritoneal surfaces as well as the greater omentum. And in this case, you see an ovarian tumor, which is one of the common primaries to produce omental and the peritoneal deposits. And in this case, the infiltration of the greater omentum will form a mass like this or a sheet underneath the anterior abdominal wall, and through this sheet you can see fat densities, vessels, and soft tissue masses. Frequently you see abdominal ascites, and this is known of course as the omental cake. And this is a good example of ovarian cystadenocarcinoma and a very big omental cake infiltrating the omentum. And the care should be taken not to mistake this as a part of the colon, for example. In these cases, you'll see that the colon and the small bowel are displaced posteriorly, and the mass is intimately related to the anterior abdominal wall. There is no air or oral contrast media inside these lesions. And many times you can see the mental cake and you cannot see the primary malignancy, which may be outside the abdomen, like lesions from the breast, for example, may produce such metastatic disease. And as I have mentioned, you can introduce a needle to have a biopsy confirming the diagnosis and detecting the primary lesion. This is omental deposits, also in a case of actually the primary malignancy here is not verified. You see masses in the peritoneum, in the omentum, and the mass shows homogeneous enhancement with displacement of the bowel loops. Then many times they may have some samples of the acidic fluid, which is commonly associated with these metastases, searching for the malignant cells to know the nature of the lesion and to search for the primary malignancy. But in my opinion, the core biopsies of the omental masses is more helpful, and this is in my opinion. to verify the nature and to detect the primary malignancy. And you also see that the liver is fatty, but there is no focal lesions in the liver. This is the case of gallbladder carcinoma. You see the region of the gallbladder fossa is infiltrated by huge mass, and inside the mass you see a radiopaque calculus. I have mentioned this before. Whenever you see a mass infiltrating the gallbladder, and you know that this is of gallbladder origin by detecting the gallstones inside the tumor tissue. Then gallbladder cancer with peritoneal deposits, and you see masses in the peritoneal cavity, and you also identify the acidic fluid. One of the helpful techniques is to let the patient drink some oral contrast media to differentiate between the bowel loops and the metastatic deposits. Finally, we came to the issue of pseudomyxoma peritonei, which means that there is accumulation of large amount of mucinous ascites due to rupture of a benign, I remember, I repeat this, benign or malignant mucin producing tumor like that of the appendix, of the ovary, pancreas, stomach, or the colon. And the CT scan, you will see that the peritoneum is filled with what looks like fluid, but of relatively a higher density. And in order to differentiate this from the simple ascites, the best way is, or the best diagnostic clue is scalloping of the surface of the liver and the spleen. And if you look to the CT scan and you see some fluid in the peritoneal cavity, and you see that the surface of the liver and maybe also the spleen is scalloped with multiple indentations over the surface of the liver, and that the spleen, and the diagnosis is pseudomyxoma peritonei, and you should look for the possible cause of this particular condition. هذا وبالله التوفيق والحمد لله رب العالمين.